Okay, this section is andrology or male reproductive system. I have a few questions. Let's do the first one. The first question is, a 55-year-old chronic alcoholic man with a 10-year history of hepatic cirrhosis came to the physician because of sexual dysfunction. Blood sample taken from the patient's cubital vein is sent to the laboratory for the measurements of testosterone, luteinizing hormone, and follicular stimulating hormone. Results are pending. Which of the following is most directly responsible for concentrating testosterone in the lumen of the seminiferous tubules? Okay, so this question is simply asking what is responsible. Amongst the choices that we're given, A, B, C, D, E, which of the following choice is responsible for concentrating testosterone in the lumen of seminiferous tubules? Okay, let's answer this question. Now, for me to answer this question, I would like to do the following. So the reason is one reason I would say is, like, why do we even need to concentrate testosterone in the seminiferous tubules? Okay, and that reason is because testosterone is a steroid hormone. Okay, so steroid hormones. Oh, my pen is not working. What happened? Steroid hormones are lipid soluble, so they can leave lipid membrane. So what I'm going to do is draw a phospholipid bilayer for us right here. Phospholipid bilayer. Okay, so just bear with me. While I'm drawing this, I'll tell you. So look, what are some steroid hormones? Testosterone, estrogen, aldosterone, cortisol, right? So these are steroid hormones. They're called steroid hormones because they make from the back. The precursor to all this hormone is a steroid backbone, which is cholesterol. Okay, so all these steroid hormones are made from cholesterol. Okay, all right. So now I'm in a position to do this. Let's do it. Here you go. This is testosterone, T. I'll just say testosterone. Testosterone. Let's say testosterone is this this red dot. So this is testosterone. Okay. So we want, because testosterone is made from steroids, which is steroid hormone, it's made from cholesterol. Cholesterol is fat. Phospholipid bilayer or cell membrane is fat. So testosterone can easily diffuse out. It can easily leak through the cell membrane. We don't want testosterone to leave. We want testosterone to be concentrated in the area so we can use it for spermatogenesis, for sperm production. So we need a protein. Let's say blue is a protein. Okay. We need a protein because proteins are large and they're negatively charged. So there's no way a protein can leak through a cell membrane. Okay. So protein cannot freely diffuse through a cell membrane, which makes our life easier. So we want testosterone to be bound. So all this testosterone that are produced should attach to this protein, and the protein will prevent this testosterone from leaking. Okay, so it concentrated. And the name of this protein is androgen binding protein. I'll put ABG. Androgen binding protein, ABP, androgen binding protein. Okay, all right. So that's the basic thing. So even if you look at these choices right here, the choices that we have, A is the only one that is a protein. The rest of them are hormones. Okay, so the only protein that can bind, and the name is self-explanatory, androgen binding protein. Testosterone is androgen, and it binds androgen, and androgen binding protein binds testosterone. That's why it's called androgen binding protein. So the answer is A, but let me do something else because this question is about male reproductive system or physiology. So I would like to talk about a little bit about male physiology. So that covers all ABC answers. Okay, let me switch to a different page. I have this app so I can do this, and I'll do this. Now I can. Okay. To answer these questions, we need to talk about the endocrine system. Okay, so the endocrine system, we have hypothalamus, H, and I'll put anterior pituitary, AP, and then let's say here are Sertoli cells. Okay, Sertoli cells. So anterior pituitary, this yellow structure, okay, and orange would be Sertoli cells, okay. So the hypothalamus produces, step 1, hypothalamus produces a hormone called GnRH, gonadotrophic releasing hormone. Look at the name. The name is self-explanatory. Gonadotrophic releasing hormone. That means this hormone GnRH acts on the anterior pituitary and it stimulates the anterior pituitary to release gonadotrophin. Right? Gonadotrophic releasing hormone is going to cause the release of gonadotropin. Gonadotropin in this case is FSH and LH. Okay. All right. So there are a bunch of cells in the anterior pituitary that are known as gonadotrophic cells. Gonadotrophic cells. Why are they called gonadotrophic cells? So let's say some blue and red just to kind of make it easy. There's two types that these produce two hormones. So gonadotrophic cells, they release LH and FSH. Okay, LH and FSH. In response to who? In response to GnRH. Okay. Okay, now I'm ready. Okay, good. All right, so step number 1, hypothalamus releases GnRH. GnRH activates, stimulates anterior pituitary cells known as gonadotrophic cells, which is blue and red dots. Gonadotrophic cells will release FSH. FSH will act on testes. Okay, testes are gonads. FSH is gonadotropin. Gonadotropin means growth of gonads. It causes hypertrophy of gonads. In this case, which testicular cells does it act on? Sertoli cells. Okay, so FSH acts on Sertoli cells, and then Sertoli cells, when they're activated in response to FSH, will produce androgen binding protein and dihydrotestosterone and inhibin. So that's the 3 hormones it will produce, 1 protein, 2 hormones. On the other hand, GnRH at the same time will act on this anterior pituitary, causing release of LH, luteinizing hormone. Luteinizing hormone subsequently would travel in blood all the way to testes and act on Leydig cells of the testes. And Leydig cells, in response to LH stimulation, produce testosterone. Okay? Okay, good. All right, so this is the general physiology of the male reproductive system. We have hypothalamus, anterior pituitary, and testes. Sertoli cells are tubular cells. Leydig cells are interstitial cells. You should remember that as well. Okay? All right. So basically what happens is testosterone. What is the function of testosterone? Testosterone is responsible for primary sex characteristics. Male sex characteristics, right? And it is responsible for development of internal genitalia. Internal genitalia. Okay. What are those internal genitalia? Well, epididymis, vas deferens, and seminal vesicles. Okay, so just to name some of them. All right. So that is the function of testosterone, right? Okay. Dihydrotestosterone, and you can include in, okay, so dihydrotestosterone, yeah, that's the next one. So let's talk about inhibin. Inhibin will cause negative feedback inhibition of FSH. So inhibin goes back and acts on the anterior pituitary cells to decrease production of FSH. So I'm going to erase that. We discussed inhibin already. Androgen binding protein, we already discussed. It acts on what? It acts on testosterone. It binds testosterone, keeps it so. Now, what is the function of dihydrotestosterone? Dihydrotestosterone acts on external genitalia. Its job is to make external genitalia, growth of external genitalia. Okay, what are those? Scrotum. Okay, so scrotum, prostate, cause growth of prostate, larynx. In puberty, man's voice becomes deep because of larynx growth. It's involved in hair growth as well, or baldness. The most important function of testosterone is spermatogenesis. Spermatogenesis is not the same as spermiogenesis. Spermiogenesis is the job of dihydrotestosterone. Spermiogenesis. Okay. Spermatogenesis, production of sperm cells, growth of sperm cells. Spermiogenesis, maturation of sperm cells. Okay. So these are the few things that we should know about it in terms of male physiology. Let's go back now. We can answer our question. So androgen binding protein was the correct answer. It binds testosterone and keeps it maintains it and locks it in the seminiferous tubules. It prevents it from leaking into other tissue. So testosterone can act on Sertoli cells to increase production of sperm cells. Okay. Follicular stimulating hormone, or FSH, we already discussed it. It's released by the anterior pituitary gonadotrophic cells, and then it acts on the Sertoli cells of testes to increase production of androgen binding protein, inhibin, okay, and dihydrotestosterone. Next thing is gonadotrophic releasing hormone. All releasing hormones are released by the hypothalamus. So GnRH is produced, released by the hypothalamus, then it acts on the anterior pituitary to release LH and FSH. Inhibin, produced by testes by Sertoli cells, which are tubular cells. Inhibin then goes back in blood, travels all the way back to the anterior pituitary and makes anterior pituitary to decrease production of FSH. So it's a negative feedback inhibitor of FSH hormone. Luteinizing hormone is produced by the anterior pituitary, and then it goes in blood all the way to the testes. In testes, it acts on Leydig cells. Leydig cells are responsible for producing testosterone. Okay. The testosterone that's produced, I'll make one more point and then we're done with this question. Testosterone that is produced by the Leydig cells is converted by 5-alpha reductase. This enzyme, 5-alpha reductase, converts, let me see why I can't write. Yeah. Okay. So 5-alpha reductase. 5-alpha reductase is an enzyme. This enzyme converts testosterone to dihydrotestosterone. Okay. So some of the testosterone that is produced by the Leydig cells is converted to dihydrotestosterone by Sertoli cells. The reason for that is because 5-alpha reductase enzyme is only found in Sertoli cells. It's not found in Leydig cells. Okay. All right. Hopefully this was helpful. Let's move on to the next question. Okay, so question number 2. A 56-year-old man comes to the physician for the evaluation of erectile dysfunction. He has been depressed for the past 10 months and has been grieving the death of his wife of 36 years. The physician prescribes him a medication that inhibits phosphodiesterase 5 activity. This medication is likely to markedly correct the dysfunction. Okay, so I don't know why the markedly, but this medication is likely to correct the dysfunction by acting at which of the following label structure in the transverse section of the penis. What they're asking is, okay, so the physician gives this patient phosphodiesterase inhibitor, which is Viagra or sildenafil. How does it act? And if it does, on which structure in this picture does it act on? Okay. So number one, so in this question, what are we talking about? Well, there's two things we need to talk about. Is number one, there is a drug, sildenafil. Okay. This drug is in market is called Viagra. In different countries, it might be called different name. Okay, so what is the mechanism of this? We want to talk about this. Number two, where does it act in the penile tissue? So this medication, at which level does it act? These structures are labeled for us A, B, C, D, E. Let's see if we remember the name. So the third thing will be, we should know the cross section, right? The cross section of the penis, which is the microanatomy. Microanatomy. We need to know microanatomy of the penis to answer this question. We need to know what is the medication, sildenafil, what is its mechanism of action, okay? And then physiology of sildenafil, right? So I want to talk about these three things. Let's see if you know the microanatomy. A is looking at dorsal artery of penis, or penile artery. Okay, and you can look at it, looks like an artery. B is a fibrous tissue. Okay, it's a fascia, or you can call it tunica albuginea, right? So that's for B. C is corpus. So C, corpus cavernosum. Okay. D is the urethra. E is corpus spongiosum. Okay. All right. Urethra is the tube through which urination occurs. Urine, it is used for transport of urine out of bladder. Okay. This tissue surrounding, and I'm going to use, let's see if I can use a yellow highlighter. So this tissue, this yellow tissue that surrounds the urethra is known as corpus spongiosum. Corpus spongiosum. Corpus spongiosum, its function is primarily to prevent urethra from collapsing. So when the penis becomes erect, it can compress the urethra. The urethra is soft, collapsible tube. So corpus spongiosum prevents that. That's its main function. Okay, next thing is this tissue, which I'm coloring green. This is the erectile tissue. This tissue is known as corpus cavernosum. The name cavernosum, you can relate it to cava, vena cava. So it's made of blood vessels primarily. Corpus means body, cavernosum means vessels in that sense. Okay, and this is the tissue that's responsible for erection. So C should be the correct answer. Okay, that's why I colored it green. So the correct answer is C. And that's where sildenafil will act on. Okay, B is a fibrous tissue, which we already talked about, tunica albuginea, or you can call it fascia, and A was the artery. Okay, now let me go to my next page, and we already answered the question, but we want to discuss some issues here. Number one, that was, what is sildenafil? Okay, sildenafil or Viagra, just so, because once you understand the concept, then you don't have to keep memorizing the same thing over and over. You can answer multiple questions because you should be able to apply it, right? Sildenafil is a drug that inhibits phosphodiesterase enzyme. Okay, to understand it, imagine there's a blood vessel. Okay, so this is a blood vessel. The blood vessel wall is made of two types of cells at least. Okay, remember, blood vessels have three layers: media, antima, adventitia. So we're going to talk about antima and media. So there are a bunch of cells. So if this was a blood vessel, this is a tubular structure called blood vessels. It has a layer of flat cells known as the endothelium. So this would be the endothelium. Endothelium. Okay. Can I, you know what, let me color this red so you know we're talking about blood vessel. There you go. Okay, so blood vessel. And in this blood vessel, something is leaking. Okay, Let me fix this. There's a leak. So this is the blood vessels. In blood vessels, we have different types of cells, right? Okay, so that's blood vessels. And let's color a yellow cell, which is the endothelium. And then we will color under that a different cell. So this is endothelium. And then just under the endothelium, we have a spindle-shaped cells known as smooth muscle. So this is the smooth muscle cell. Smooth muscle cell. Okay, so two cells we're talking about, endothelium. Now, what is the importance of that? Because endothelium will take something, an amino acid known as arginine. It converts arginine to citrulline and nitric oxide. The enzyme that produces this is known as nitric oxide synthase. Okay, so I'll just label it NOS, nitric oxide synthase. So nitric oxide, when it's produced, nitric oxide, you know that it's a vasodilator. Nitric oxide can diffuse. It's like small molecule diffuses into the smooth muscle cells. When it reaches the smooth muscle cells, in smooth muscle cells, there's another enzyme called guanylate cyclase. Guanylate cyclase. So this guy, the guanylate cyclase, takes GTP, and converts it to cyclic GMP. Okay, good. Cyclic GMP, in effect, will cause decrease in intracellular calcium. And this decrease in intracellular calcium causes muscle relaxation. Okay? And this muscle relaxation leads to vasodilation. And that's what we want. Okay? Vasodilation. So as the blood vessels within the corpus spongiosum dilate, it can keep more blood and expands. Just like if you look at the firefighter hose, you know, when it's full of water, it's erect, it's hard, and expanded. Same scenario applies here. Okay, so far this is a normal physiology. Okay, but I'm going to change my color. Cyclic GMP can then be converted to GMP by an enzyme known as phosphodiesterase 5. Okay, which means phosphodiesterase 5 will decrease the amount of cyclic GMP. We don't want that. That's where sildenafil will come. Sildenafil will come and block this enzyme. When it blocks the enzyme, so cyclic GMP will increase and will stay high. You wouldn't be able to deactivate it or convert it to GMP. So as a result, the muscles of these blood vessels will stay dilated or relaxed. Okay, so it will maintain vasodilation. So that's the physiology. Remember that. And the guanylate cyclase is soluble guanylate cyclase. Okay. Okay, so this was sildenafil. Now the next thing is this drug has some side effect. Before I go with these questions, before I'm done, let's talk about some side effect of this drug. Obviously, if it causes vasodilation, so it can cause vasodilation and therefore increase blood flow to your brain, and that can lead to headaches. Okay, headaches. Why am I going so fast? Let's just put headaches. So that's one of its side effects. And if you have, increased blood flow to the skin, obviously the skin blood flow increases and skin color can change with increased blood flow. Just like when you exercise, when you get scared, or when you, what else? Get nervous, skin will become flushed. So it can cause skin flushing, okay? So that's another side effect of Viagra in this case. One of the important side effects is priapism. which is in one of the movie when De Niro takes the medication from, I forgot the name, the actor. Okay, one more, it can cause cyanoopsia. Cyano means blue, opsia means vision. It gives like a blue tinge to your vision. So you see things in a blue tint. But one of the most important side effects is hypotension. Remember that sildenafil is a vasodilator. If you specially take it with other vasodilator like calcium channel blocker, maybe nitrate and other medication, it can cause severe hypotension, which could be fatal, so you have to be very careful. Most people who have erectile dysfunction already have coronary vascular diseases, hypertension, and other diseases which requires like nitrate, calcium channel blocker, beta blocker, and things like that that decrease blood pressure. So if you have two drugs that both decrease blood pressure, the effect can be doubled and it can cause severe hypertension that can be uh, fatal at times. Okay, let's move on to the next question. Okay, question number 3. A 26-year-old man comes to the physician because of a 10-day history of fever, painful urination, and urethral discharge. These 3 symptoms, fever, painful urination, and discharge, reminds me of some STD. Okay? Okay. So, and he's young. Look at the age, right? So you should be thinking of STD at least. Maybe it's not the answer, but nothing wrong to think like that. It makes your life easier. He is sexually active with multiple female partners. There you go. So, and does not use condoms. Physical examination shows a thick green urethral discharge and tenderness, an exquisite tenderness of his left testes. Scrotal elevation relieves the pain. Gram stain of the urethral discharge is shown. That's this picture, right? Which of the following bacteria is the most likely cause of this patient's condition? Okay, so we want to know what is the cause of this. So we're looking for a bacteria. Okay, so the question is telling us which of the following out of the choices A, B, C, D, E, which of them is a bacteria and which of those bacteria is the cause of this person's condition. So first we have to diagnose, but before we even diagnose, let's look at the choices. In the choices, Neisseria gonorrhea is a bacteria, okay. Chlamydia is a bacteria, yes. Mycoplasma is bacteria, yes. Trichomonas is a protozoa, it's not a bacteria, so I'm going to cross. And then ureaplasma is a bacteria. So out of the 5 choices, now we have 4 because D is incorrect. It's not a bacteria, so we're not going to talk about it, or we're not going to choose this option. But just to look at this gram stain, the gram stain is at least gram negative because gram negative cells stain pink. So this is gram negative. Okay, and if you look at it, you can see round cells. Look right here, round cells, and I'm going to circle them for you. Round cells in pairs, they exist in pairs. But most importantly, look at this neutrophil. Look at this neutrophil. So these cells exist in neutrophil, in the diplococci formation. Round cells that are in pairs. Usually these are known as kidney bean shaped diplococci, right? Okay, let me change my color to red so you can see where I'm writing. So this stain shows gram negative cells that exist in diplococci form. So to look at it, Neisseria gonorrhea is gram negative and is diplococci, so we'll keep that. Mycoplasma genitalium. Mycoplasma doesn't have a cell wall. It doesn't have a cell wall, therefore it doesn't stain with gram stain. So I'm not going to even choose this. Mycoplasma doesn't stain. It's wall-less bacteria. Ureaplasma is also wall-less bacteria. Okay, it doesn't have a cell wall. It doesn't have the peptidoglycan layer, so it doesn't stain with the gram stain. So those 2 will be out. So now we're left with A and B. A and B both are very common causes of STD in young men and women, especially those who don't take precaution, who are sexually active with multiple partners, like this person is. He doesn't use condom and he's sexually active with multiple female partners. Okay, so this would help us. Now, Chlamydia is intracellular parasite. Chlamydia is intracellular parasite. It's obligated intracellular parasite. It does not exist on its own. It can't survive, or it can survive in the different form, but it cannot reproduce itself. It needs living cells, like epithelial cells. So if it was chlamydia, you should see inclusion bodies within epithelial cells. The inactive body of chlamydia is known as reticular body, which is found in inside the cells. In the environment, it's known as elementary body. Okay. Neisseria gonorrhea are swallowed by neutrophils. They exist in Diplococcus form. So the answer should be Neisseria. Okay, so that is the correct answer. But let's. I'm going to erase this just to make sense out of it. Okay, I'm going to erase this gram stain. You guys already know it, but let me do something else. What else can I do? I think I can do this. No, it doesn't do that. Okay, maybe let's erase it. Okay, this should do it. There you go. Okay, now I can do that. Okay, so let's talk about this. Urea plasma is has no cell wall. No cell wall. It has no cell wall. Mycoplasma has no cell wall. So these two bacteria are similar. If they don't have cell wall, they don't stain. The only way we can identify bacteria, whether they're gram-negative or positive, is based on their cell wall. And their cell wall is made of peptidoglycan layer. So they have no cell wall, they don't stain. Both of them require cholesterol for growth. So both of them, because remember, if they don't have cell wall, cholesterol. If they don't have cell wall, that means they have to live in the environment with their membrane only. And membrane stability requires cholesterol. This is why human cells, our cells, have cholesterol in the cell membrane. Okay, so they require cholesterol for growth. Urea plasma is urease positive, which means it splits urea, okay, into ammonia and carbon dioxide. Okay, whereas mycoplasma is called agglutinin positive. So just to differentiate between the two, mycoplasma can cause agglutination of red blood cells at lower temperatures, whereas urea plasma can produce ureas, which will split urea into ammonia and carbon dioxide. So that's to differentiate between the two of them for future. Protozoa, Trichomonas is pear-shaped or peach-shaped, whatever you want to call it. Single nucleus. Flagellated. It has flagellus, flagellated. I'll just say flagella. It has four flagellus. Okay? So it's motile. It's a single cell organism. Okay? That's Trichomonas. The reason I'm mentioning four flagellas, because Giardia has 8 flagellas or 4 pairs. Okay, chlamydia. Chlamydia is obligated. Obligated, that means it has no choice. Intracellular bacteria. So it cannot reproduce by itself. It needs cells. So that's why you will see epithelial cells. So if you were to see a gram stain or anything, you will see epithelial cells. Epithelial cells with inclusion bodies. Okay. Neisseria, you will see gram-negative diplococci within neutrophils. Okay, so that's how you identify them. Okay, hopefully this was helpful. The second thing I want to discuss in this case is this person had, remember, they had fever. Okay, they had dysuria or painful urination, and they had discharge. When you see these three symptoms, you should think of STD plus, young, male or female, with multiple. Even if you don't have the multiple sexual partner, right? If you don't have that. So this will immediately think of STD. In this case, in addition to that, the person also had tenderness. Remember, testicular tenderness. So this will cause STD. So this can be urethritis or anything else. But to have testicular tenderness, so when you palpate the testes, if there's a pain on palpation, that is tenderness. And then when the testicular elevation, so when testes are elevated, decreases or relieves pain, right? So this can be urethritis, right? This first one, let's say this one, urethritis. But when you add these two, it becomes epididymitis or orchitis, infection of the testes. Okay, so diagnosis is really important. You should be able to diagnose a condition which you make. So this question that we did already, number one, we had to diagnose, and then number two, we had to identify the bacteria. So diagnose first, and then identify the bacteria. Okay, so it was a two-step question, but we did it. Next thing is that imagine this is a bladder, or let me just get rid of this. Yeah, so here this is the bladder, and here is the prostate, and then this is the urethra going through the prostate, and then remember there is the seminal vesicles, and then the vas deferens goes all the way. Let's say testes are down here somewhere. Okay, so this is the testes, right? So usually when a patient has epididymitis or orchitis, they should already have urethritis. Okay, so bacteria usually will be coming from the urethra because it's STD. That means sexual contact, right? So bacteria goes through the urethra. It can travel to the prostate, cause prostatitis. It can cause cystitis if it travels to bladder. And if there is, let me go more. Let's say there is ureter, and these ureters travels to the kidney. So it can cause, when the bacteria travels to kidney, so let's say from here it travels here to the kidney, that will cause, so number one, prostatitis, right? Prostatitis. So that's number one. And if it travels to the bladder, which is number two, let's label them here, it will cause cystitis. And if it's further traveled to the kidney, let's say number three, it will cause pyelonephritis. This patient didn't have any of these, so I'm just telling you, so but if the bacteria comes through the urethra and it causes urethritis, I should have labeled that one, so let's label number four, urethritis. This person had urethritis, right? So he had urethritis. That's the prerequisite for, because the only way you can have prostatitis, cystitis, pyelonephritis if you have urethritis. or bacteria cause infection, the area that comes in contact with first. But some of the bacteria can go to the vas deferens, seminal vesicles, and it comes all the way to the in this top part of the testes is the epididymis, and then this is testes, this is epididymis. So it can cause that infection. So this patient had urethritis and epididymitis. So number 5, epididymitis. Just so you know some anatomy, okay? All right, let's move on to the next question. Okay, the next question is a 68-year-old man with a 10-year history of diabetes, mellitus, hypertension, and hyperlipidemia comes to the physician because of 6-month history of dysuria, nocturia, frequency, weak stream, hematuria, and fatigue. He smokes 1 pack of cigarettes daily and occasionally drinks alcohol and smokes marijuana. He has had 2 episodes of urinary tract infection during the past 6 months. Today, his temperature is 38, which is high, pulse is normal, respiration is okay, and blood pressure slightly low. Physical examination shows suprapubic tenderness and diffusely enlarged soft prostate. Okay. Abdominal pelvic ultrasonography shows enlarged bladder with diverticuli and enlarged kidneys with distended renal pelvis and calyces. A urine culture grows E. coli. Which of the following is the most likely underlying cause of this patient's condition? Oh, there's a lot of things going on. Okay, so number 1, let's look at this. This person has, they're telling you the ultrasound. On ultrasound, this person has benign prostatic hypertrophy, right? So it's telling you the ultrasound shows enlarged, So on physical examination, this person has diffusely enlarged soft prostate. So that's prostatic hypertrophy or hyperplasia. It's diffusely enlarged. If it was just a single nodule, then you will think of prostate cancer, okay? So if they use a term, there was a single small nodule on physical exam in the prostate, so you will think of prostate cancer. But if the prostate is enlarged and it's firm and it's not tender, it's prostatic hypertrophy. But if the prostate was enlarged but tender, then it's prostatitis. Okay. It's telling you it's soft. It's not telling you it's tender. Instead of soft, if they use the word tender, then it will be prostatitis. Okay. So that's benign prostatic hypertrophy. So the symptoms of benign prostatic hypertrophy, let's go here. This is the bladder, and here is the prostate. And then within the prostate, you have urethra. Okay. So in benign prostatic hypertrophy, what happens is, I'm going to use green, the zone around the urethra, I'm coloring it green. That's called central zone. See the zone that I colored green in the picture above, the green zone, that's periurethral zone or central zone. When this area hypertrophies, it's going to compress, it'll put pressure, it'll compress the urethra. I'll put these arrows. So as a result, the urethra can become constricted. So there will be some obstruction. So there will be bladder outlet obstruction. Okay. So benign prostatic hypertrophy can cause bladder outlet obstruction. What are the symptoms of bladder outlet obstruction? Obviously, difficulty urination, right? So dysuria. You'll be looking for that. Okay. Nighttime urination, because there's a lot of urinary retention at night. Bladder is full, so you feel like going to urinate more frequently, and there will be frequency. Okay, because the urine flow is obstructed, so urinary stream will be weak. Okay, and there will be urine incomplete. Let's just put this one as well. Incomplete, feeling of incomplete emptying of the bladder. So these are signs of urinary flow obstruction. Kidney stones can cause that. Bladder cancer can cause that. But in this case, benign prostatic hypertrophy can cause it as well. Okay. All right. So number 1, we diagnose this person to have benign prostatic hypertrophy. But there's 2 additional things if you look at it, this in this question, they are also telling you the person has hematuria. Okay, so the person has hematuria, and he's been smoking. So that puts you at risk of bladder cancer. Okay, but bladder cancer, you would have seen it on ultrasound. Um, Maybe weight loss is not other stuff. So just to sort of like remind you to read these questions carefully. Okay. All right. What else? Next thing is, so that's one complication of this. So another complication of this benign prostatic hypertrophy is recurrent UTI. Recurrent UTI because urine flow is obstructed. Urine doesn't flow as before, so it doesn't wash bacteria down the urethra and outside, right? So bacteria can actually accumulate in the urinary system, especially those bacteria that have pili or uh, fimbriae that can attach to the urinary epithelium, such as E. coli, can cause infection. So they're telling you this person had E. coli infection, and there was suprapubic tenderness, suprapubic tenderness that makes it cystitis, tenderness, tenderness. Okay, so that's another complication. But if the urine flow is obstructed for a long period of time, then the ureter, remember, urinary backflow will accumulate in the ureter, right? So the bladder is full, and urine backs up, and it backs up in the ureter. So you can have enlargement of the ureter or distension of the ureter. It's called hydronephrosis. And if urine keeps piling up in the ureter in the kidney, can lead to kidney dilation, bladder diverticuli. Okay, so the bladder wall becomes weaker and expands and balloons out. That's called diverticuli. Um, if this is the kidney and here's the ureter, so the kidney has these calyces. As urine accumulates, it pushes on these calyces, and these calyces, the major and minor calyces or the renal pelvis, can expand. So this can go and dilate and become enlarged. Okay, and the kidney will atrophy. And that's what the question is telling you. So that this person has enlarged kidney with distended renal pelvis and calyces. So these are all complication of BPH. So remember that the complication of BPH is benign. BPH is bladder outflow obstruction, which will have its own symptoms. It puts you at risk of UTI, and it puts you at risk of hydronephrosis. Three things in this question that are discussed: hydronephrosis, UTI, and bladder outlet obstruction. These are all complications of benign prostatic hypertrophy, and that was the answer. Okay, question number 5. A 9-month-old boy is brought to the emergency room by his parents because of a 48-hour history of a bulge on the left side of his groin. So there's a bulge on the left side of his groin. Parents report that when the child cries, the bulge increases in size, and when he is quiet, it disappears. Physical examination shows an easily reducible soft mass in the left scrotum. So there's a mass in the left scrotum, okay, which increases with crying and decreases when the patient is relaxing and quiet. So it changes its size. Okay, which of the following best describes the relationship of this hernia sac? Okay. A, lateral to the inferior epigastric artery and inferior to the inguinal ligament. Okay, so this talking about inguinal hernia. Let's go talk about inguinal hernia. Okay, now to understand inguinal hernia, we need to draw, let's say there is femoral vein, okay, and then there is the femoral artery, okay, and then we need, what color? Gray. Let's use here the rectus abdominis muscle. So maybe I should color it more brownish, that looks like a muscle. Okay. Okay, so that's the muscle. Let's make it a little bit lower. and then silver color or just gray, basic gray. So there will be the inguinal ligament. Okay, so this is the inguinal ligament. Let me label these things for you. So that way, so inguinal ligament, inguinal ligament. Okay, this is rectus abdominis muscle. Okay, so muscle, rectus abdominis, and then red is femoral artery, blue is femoral vein. Okay, okay. There will be an artery that's given. This is the inferior epigastric artery. Inferior epigastric artery. Inferior epigastric artery. Okay. So these are some things that we should know. And then right here will be superficial, deep inguinal ring, and here will be superficial inguinal ring. So when it comes to inguinal hernia, so rule number one, let's compare them. Inguinal hernia, I wish I would have had more time, more space. Inguinal hernia, let's compare inguinal hernia to femoral hernia. Okay, so inguinal hernias to femoral hernia. Inguinal hernia will always be above the inguinal ligament. Always above, I'll put IL, inguinal ligament. Whereas femoral hernia will always be below. That's one way of differentiating them. Below inguinal ligament. So femoral hernia will be right here. I'll put yellow area. Let's see. Let's color this yellow. So this is the area of femoral hernia. Okay, this is the area